you're talking. Well, I have several important things to say. I'm a pediatrician, not only a pediatrician, but I'm an ICU pediatrician. So really small attention span, no attention to details at all. You think Carol was a little loose on the language? Yeah, I won't even be close. But I do invite questions anytime. You can ask questions anytime. Anytime I can start and stop all the time. That'll be good. I'll take all the easy ones, all the hard ones. We'll go to my stunt double. There's another Jeff Thompson here sitting in the crowd. So I'm just the pretty face. He's really the brains and does all the work. So it works out great. I'm going to tell a story to begin with as well, but I'm just going to change it up a little bit. I mean, I got a chance to speak at the National Academy of Science, and it had been closed for 2 years. It came out, and CTAC helped put a big conference on about advanced care planning. And everybody in Washington was still 2 or 3 years out from the death panel stuff, and they're all flopping around. And I said, you know, I had the whole noon, I had 500 staffers, and I just said, this death panel stuff's a bunch of crap. And you need to get smarter and behave differently. If you're taking care of your contingency at all, you got to do something. You got to behave differently, and it was great, and it worked well with the crowd. But of course, we had put up with all the media coming to Gundersen to find all the death panels because we had helped write the legislation. But everybody that spoke that day, every senator, every staffer, every head of the American Heart Association, AARP, everybody started with their own family story, because every family has a story. So I'm not going to tell that story. I have that story too. I'm going to tell a story about a wedding, son's wedding. Son's wedding, Milwaukee, big art museum down by the lake. It's going to have this giant reception, this beautiful reception. So we get down there early and we're going to get pictures taken. So I have this little tux on, and I'm walking down this hallway with my daughter. She has a beautiful gown on. She is one of the ladies, maids in honor or something, walking along with outfits on. They all have outfits, extraordinarily beautiful and expensive outfits. And so somebody comes running in the door and said, we understand there's doctors in this wedding party. Well, actually, several of us, but yeah, what do you need? So, well, there's a lady about to have a baby in the parking lot.
Oh my goodness.
I've been to, 5,000 deliveries. I've delivered lots of babies. It's not a big deal, but I haven't even had the pictures taken. My daughter-in-law, yeah, this is going to be bad. I said, come on, Rach, let's go. So here we go, and Rachel's carrying her little dress, and she's running in her high heels, and we're running across the thing. And of course, what does the kid say? She's a pediatrician. She's smarter than I am. She's very strong, recently trained. What does she say? Dibs on the baby, Dad. Come on, what do you mean dibs on the baby? You're recently trained, you're a woman, you're saying you should do the mom. She said, you deliver more, you do the mom. So, yeah. And so we get there, and here's a woman walking away in a gown, not from our wedding party, different wedding party. She's walking away, and she had just looked in, saw the babies out, and just kind of kept walking. So I went to the front seat where the mom was, and Rachel went because she had leaned back. So Rachel went back to take care of the baby, and so I started talking to the mom, and blah, blah, get some information, and we tie off the cord, do the things you do, and policeman shows up. Policeman sees the baby's out. What's the policeman ask? He asks the next thing on his protocol, right? He says, have you delivered the placenta? I told him no. He said, well, we need to do that. He starts putting on his gloves. I said, actually, we don't, because I actually talked to the mom. I talked to the mom, and I said, what happened to your is this your first delivery? He said, no, second delivery. I tried to deliver at home last time, almost bled to death. Placenta didn't come out. When it came out, I almost bled to death. I was in shock. I was unconscious when I got to the hospital. That's bad. I mean, I'm a pediatrician, but I know that's bad. So I said, I'm not delivering your placenta. So I said to the guy, no, you hold off. He says, no, we got to do that. I said, yeah, I know I'm in this outfit, but I'm a doc. I'm an ICU doc. I'm going to take care of this patient until somebody is willing to take care. But nobody's delivering the placenta on this woman. Okay, so they're getting ready. The ambulance shows up 2 minutes later. EMT gets out. Thoughtful young man. Sees the baby, sees the mom. says, have you delivered the placenta? And I said, no. Will you stop asking, have you delivered the placenta? He says, no, I just asked once. I said, I don't want to hear it again. And I will drive this person to the hospital 5 minutes, 4 minutes away in my own car if you guys demand to take out her placenta. She almost bled to death before. Talk to the patient, understand the patient. Here's what this patient's need. This person needs a different level of care, a different type of care. You don't understand that unless you talk to the patient. You got to talk to the patient. That's my personal story. I'm going to back it up. I'm going to back it up with a lot of horsepower. Here's the horsepower. There's a group that I'm part of. I don't know why I'm part of it, but a bunch of very fancy people and me meet in Aspen every year. 6 secretaries of Health and Human Services, former secretaries, heads of giant organizations, CVS Pharmacy, the Marriott Corporation, Kaiser Permanente, all these mucky-mucks. The woman that up until this week had the IBM Watson program. All these people, national big figures. We spent a week trying to figure out how do we move ahead the care of chronic disease in this country. Here's what their basic principles were. None. No. They had principles. How are we doing here?
Keep going.
Keep going?
Keep going. I'll flip you up.
Okay, so as you can see on the slide,
There you go.
these, you got it? Thanks, dear.
It's thinking.
Oh, yeah. No, you're a pro. See? And this is the way medicine goes, too. The internists, they know how to do things and get things done. The pediatricians, they talk and entertain. So what did they say? There's this very powerful group. What were the highlights of how to move ahead chronic disease, how to take on obesity, how to take on heart failure and asthma and these kinds of things? The language, what do we need? We need the voice of the parents. We need, or voice of patients, engage patients and their families. We need to coordinate this care. We need to give skills to the team. This sounds a whole lot like the 5 pieces we just talked about, right? So here are these very smart people. They're agreeing completely. This is where we need to go. Here's another big piece that we need to go. We have to say we're not nearly as good as we used to be. This is a big problem. This is a big problem in healthcare. People think they're doing fine. What they're doing fine is, actually they're just mediocre. Actually, we're less than mediocre. You know our health data now, our health data, immunization rates, pregnant women getting seen, that stuff, is right even with Rwanda. Rwanda. And why is that? This is one of the hardest things for me to get my head around, is that the reason is because that's what we pay for in this country. We don't pay for health, we pay for doing things. Well, there's all kinds of people that do things not necessarily for money, but ultimately that's what drives it. The problem is we need to switch to a purpose-driven healthcare. Think of Mr. Kramer last night, for those of you that are here. Mr. Kramer, the man with ALS, he talks about purpose. You talk about an organization. How did we drive Gundersen to do what we did? It's because it was a purpose-driven organization. We focused on the health and well-being of patients in our communities. I mentioned earlier in the panel this morning, when you look at our strategic plan, it was outward facing. This is outward facing. Distinguished through excellence and improve healthcare of the communities, be as good as anybody in the country, quality through the eyes of the patient, involve the families in the patient experience, a culture of caring, and a spirit of improvement. We're not as good as we should be. We will care and we will get better. This is outward of the finance. Affordability doesn't make more money. It's become more affordable. This is outward facing. So one of the fundamental pieces in this is to say, how do we turn it away from our own little aggrandizement, our little monthly finance report, and how do we turn finances into a tool, not an outcome? Finances should be a tool, an important tool, a good tool, but it's a tool. I didn't say the finance people were tools, although many are. I'm just saying You know, I'm really popular at CFO meetings, let me tell you. I'm very popular. They love it when I tell them that. But it's about serving a higher purpose. And you say, well, it's fine, that's board speak. So no. It turns out we disseminate that, and I'm going to talk about that a little bit, across the whole organization. It's the purpose. So this is I mentioned awful about a tool. So this is something that a tool wrote about us. A tool wrote about us after he had spent some time talking with me, and he called up. He said, Jeff, well, I want to talk about what you do. And I said, why don't I give you two? And actually, this was a Greg Thompson, not a Jeff Thompson, a guy in the ICU. So if you look up this article, there's a Greg Thompson. There's Greg Thompson, who's an adult ICU guy. And he walked down through the ICU with a cell phone in his hand. He didn't give out people's names. But he told a tool, as a tool, in Boston, walk down his ICU. Who's in your first bed? Greg said, well, it's a 64-year-old woman, post-cardiac surgery. She'd had some other complications. She should be here a day, off the ventilator tomorrow morning, out. She'll be fine. Who's in your first bed? First bed is 79-year-old man, pancreatic cancer, Mets to the brains, infection in his lung. He's on a ventilator. He'll be 3 weeks, and then he'll die. We go to the next patient. Who's in your next patient? This is a car accident patient, blah, 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 has this and that. That probably be 3 days in the ICU. A tool, what's your next bed? Next bed is a 72-year-old woman with ovarian cancer, disseminated cancer, 2 infections, heart failure, renal failure. She'll probably live here 3 more days and then die. 80% of the people in a tool's ICU would never have been in our ICU. Would never have been in our ICU. And the reason is because we'd have gone upstream. We'd have had a different set of conversations. We'd have done things remarkably differently. We wrote a book after the death panel stuff with contributions from people all over the country. This is a theme you see going through this conference. It isn't about the dying. It's about the living up to that point. We have to get smarter about what we're doing. So this is, at Gundersen, this is one of the things that it became pretty clear pretty quickly. You couldn't just scream at the health professionals. You just couldn't have them fill out forms, even if they're filled out thoughtfully. What you had to do is have a system to support it. That's why I tell a story about going to Boston. They had worked on the front-end stuff. They had thoughtful forms. They had them filled out, and they didn't make them available. They didn't invest in making them available. They didn't train their staff. They didn't have hospice. They didn't have home care. They didn't have palliative care. They didn't do all the things to support it. They didn't manage the medical staff and the nursing staff, the social service staff, to actually do something better. So that's filling out more forms or screaming at the providers. It turns out it didn't work. It didn't work. You had to do other things. These are things that we saw along the way that have been mentioned in multiple pieces. This wasn't an accident. This had to be put into the common language of how we did work in the organization. Okay? So as we trained students, as we trained residents, as we had case conferences, this was risen up, surgical conferences, medical conferences. We brought this up as this is a way that we're going to continue to take care of patients. It isn't what we can do. We had the capability to just pull out the placenta. It's what we should do. We should leave it in so she doesn't bleed to death. Okay? Not exactly the greatest image for you that have gone through that, but sorry about that. You know this. This was a big movement for us to get it out of the mindset of, you wait till see people desperately ill and you fill out a document. We pushed all past. No, we have these conversations when people are good, when they're healthy, when they say, oh, good, now we got that done, check. That isn't good enough because things change, people change, lives change, illnesses change. They all recognize this graph of people's lives, But what they didn't recognize is that we need different activities that go along with that. So we had to build that in. We had to teach them that it's a whole package of connectivity. It is, from the patient's view, it looks like a bowl of spaghetti. We put these nice little bubbles here. But from the patient's point of view, it's all this tangled web of things that go on. But it's really all connected. Our job, not the patient's job, our job is to make it work for them. If our interest is in the health and well-being of patients and community, health and well-being. So somebody raises their hand and says, I'm not sure it's my job. I was trained to take care of heart failure. Why is it my job to do all this stuff? Well, your job is not to do all that stuff. Your job is to be a part of all that stuff, to connect with the stuff. This is why I argue with the tool, that people connect into healthcare in many different places. All those physicians, hardly any of those physicians, are going to be particularly good at coordinating all this work, of having that hour-and-a-half conversation and recording it in a thoughtful fashion somebody else can understand and putting it in a place where they can find it. There's just, the world of physician gets tiny and tiny and tiny. Who's really going to do that? That's why we need, our responsibility as physicians is to be a part of this team, not the kingpin, be a part of the team, not abdicate our responsibility to start having those conversations or get people moving, but be a part of that team. It comes back to, why do we exist as an organization? What is our purpose? Health and well-being, patients, our community. Does it dominate the world? It's not. It's health and well-being to patients and our communities. Now, does that mean that was all soft and mushy? Gosh, we measured like crazy. We measured all kinds of things. In fact, very early on, Brenda Rooney, one of our public health people, Bud, they measured very early on what was our impact, how many were being filled out, how many are being followed, when they weren't being followed, what were the issues, why weren't they, how do we get better? This required a great deal of discipline. In fact, my contention is that when you try and live your values, it takes a variety of characteristics. One is courage to just say, here they are. And this is where we're going to live. We're going to take care of the health and well-being of patients and communities. We're going to value integrity and compassion, respect. These are the things we're going to value, and we're going to live that way, and we're going to be successful that way. Regardless of how you measure success, that's how we're going to be successful. We're going to live. We're going to courageously put that down. We're going to have a discipline to follow through on it. And I'm going to show you an example of that pretty quickly here. And then you have the durability, whether it's the death panel blow-up that happens, or whether it's some mistake in the organization that happens, with a staff member that goes wild and behaves badly. You have to have the durability to take that on. So it's all these things. But it all goes back to a purpose-driven organization. So lean, we were never a designated lean healthcare organization. But I speak at lean conferences all over the world. Why is that? It's because you remember lean is from the Toyota manufacturing system for cars. Well, what's it doing in healthcare? Actually, it's doing great things in healthcare. Because lean, initially, people look at it and say, oh, it's stop the line and stop manufacturing, and we're doing people, not cars. Yeah, that's very superficial. You look deeper, and it's all about empowering the frontline staff, to solve problems that improve value to the customer. Frontline people solving problems focused on the well-being of who we take care of. That can work in healthcare, right? That can work. So if you get lost in the tools, this tool and that tool and some Japanese names, and people kind of spaz out about that, that's a problem. Of course they don't get anywhere. Of course they don't accomplish anything. If you move to systemizing that, so then you move it across places, you can get some progress, you can accomplish some things, but it's hard to get it to stick long term when you have a vice president leaves or the senior vice president, she leaves, she takes a different, retired, does something. It's hard. You get it to a principle-driven, it's about the principle. It's about taking care of the staff so they can take care of the patients. It's about taking care of the system so you don't bankrupt. It fits completely with an organization that's dedicated to improving the health and well-being of patients in the community. It's perfect for a principle-driven, outside-looking organization. So this is the setup. So when I talk about you start with the board, you start convincing the board, this is where we're going to go. You tell them we're not going to get wild about every week's finances. We're going to get wild about the care we deliver, whether we're talking to the patients or listening to the patients, whether our staff are being given the tools to really accomplish what they need to accomplish. So the medical staff always comes up. Carol's done a lot of work with this. Here was our biggest early statement on improving the culture. So we had a medical executive committee that actually employed all the doctors, and 95% of them. And we functioned in a certain way. We had very technical, big formulaic things that would say, would you let that guy take care of your husband? No? We couldn't take care of my wife either, so we're probably done here then. I mean, actually we had a lot more data than that, but it came down to, would you allow, if you wouldn't allow a family member to be seen by this person, they shouldn't be allowed to see anybody in our place. So we try and fix them, we try and make them better, we try to do all kinds of things to make it better, but if they refused, then they couldn't practice in our organization. We said we had to codify it, so we worked with a group. There's a process, and I'm happy to tell you the process. I don't need to go through that now. Of rising clinicians, it's part of my responsibility, our responsibility as senior leaders. If we expect the physicians to lead, we've got to give them the tools to lead, give them some leadership training. Most of them never, all of them have been asked to lead. Almost none of them had any leadership training. So we had an ongoing leadership program, big, wide pyramid thing that would prepare people to be a senior leader of a department of the organization or the CEO. So we got that group to work on this. And the fundamental of the piece is, as an incoming physician, you might be the most brilliant neurosurgeon in the country. But I want to be clear what I will give to you. Here's what I'm going to promise you. I'm going to promise you all those things on the left side: a great place to work, focus on quality, high quality staff, change management. But here's what you're going to promise the organization. You're going to promise the organization you're going to lead on quality and service. You're going to take ownership. You're going to lean in on change. And you're going to treat all people with respect. All people. Patients, families, social workers, colleagues, administrators, doesn't matter. Treat everybody with respect. If you can't do that, don't apply. Don't send your application back. When you come for your orientation or for your interview, we showed you the same thing. We said, this is how we live. This is how we live. Some people say you can't develop, culture is what happens. You can't design a culture. I said, that's baloney. You can design a culture. You decide where you're going to go. You decide what's important, and you just press for it. You just have the courage to go after it. Sir?
Questions about the culture before and after the compact.
Yeah.
So did the compact just codify what the culture was, or did you change the culture by creating the compact? And in that process, did you lose some people along the way? Was it disruptive? Because you have to set expectations.
Right. So the medical vice president that came in when I was medical vice president, in fact, started behaving consistent with this, and we did lose some people who refused to go in with this. And one of the stories I tell often is a neurosurgeon who's fabulous, did deep brain stimulation, did all kinds of stuff. Great outcomes. His quality outcomes were terrific. He calls me up one day and says, Jeff, think I might be in trouble. I said, why are you in trouble? He says, well, I hollered at a security guy. I said, why'd you holler at the security guy? He said, well, I put a ticket on my car. Where was your car? Oh, we're by the East Building, blah, blah, blah. I said, oh, in the fire lane. He said, well, yes. I said, you know, there's a reason we don't have cars there. He said, well, no, if the fire alarm went off, I was going to come down and move it. I said, that's not the point. You know, they don't cost you anything, not that he can afford it. They don't cost you anything. Why are you hollering at this guy? Ah, he ticked me off and blah, blah, blah. I said, what'd you say to him? He said, well, I told him he should get a job that's worth something, and I make more in a week than he does in months. But I didn't say anything. He says, you going to fire me? What do I tell him? You say you fire him. One mistake and fired? Do you do that in your organization? One mistake and you fire?
That's a pretty bad mistake.
No?
Word to the wise is sufficient.
So here's, to shorten up the story, here's what happened. I said, depends on you. It depends on you. If you apologize to this man, if you send a note to his boss immediately, because of course it's been 20 minutes, so everybody in the organization knows it now. And if you commit yourself to work on this and really lean on treating everybody with respect, then we'll work with you. But if you can't, you might as well put a sign in your yard. He said, I put $5 million on the books last year. And I said, you know what, I'll miss that. I'll miss those $5 million. But you know what? I can't have you slaughtering a nurse at 7:30 in the morning on round someday, and then her making mistakes on patients for another 11 and a half hours. That is not fair to her. It is not fair to the patients. It's not fair to our organization. Won't allow it. Won't allow it. We'll help you do anything to get better. No different than quality. No different than the orthopod whose ankles aren't coming out right, the pediatrician that has trouble putting chest tubes. No different. We'll help you do everything we can. But if you are unwilling to participate, it's the wrong place for you. So we started moving in this direction, but we said to help people. Remember, holding accountable is looking backwards, right? Being responsible for their success is looking forward. So there's some combination of there. To be responsible for success, we got to give them a way forward. So we tell everybody multiple times before they ever touch a patient, here's how you got to live. Here's how we're all going to live. In this culture then, in a culture like this, where you treat everyone with respect, you can see you can translate that pretty well to treating a patient's wishes with respect. It is a part of how we live and how we breathe all the time. You can't allow somebody's ego to be more important than the well-being of the patient and the staff. That goes for the CEO, chief financial officer, any doc, any administrator. Doesn't matter. Doesn't matter. It can't be ego-based. And you got to do something about it. Remember that discipline? Here's the discipline. Here's how we measured senior people in the organization, all the directors, and we took it from GE, but they didn't invent it. It was a 9-box. It's performance and potential. And the key here, a lot of people do that. We got a rising star, and what's her performance, and what's her potential, and her vice president says she's so bright and brilliant, and blah, 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 and she does all these things. She'll be running the place in a few years. We say, great, put her up there. We'll do that. What about your next person? He's great too. He's great. He's done all this stuff. And the people around the room say, who are you talking about? He is a jerk. He works on our team. Nobody will work with him. Nobody. He never does his job. He treats people badly. He does all these things. He's really bad. The whole rest of the group says he's a disaster. She says, no, he's really good. He just sucks up to you. He's got you hoodwinked. You're missing it. Why do we do this? Teach each other. But the other thing is, you thought that guy was great? All these guys thought he was terrible. All right. But you know who's responsible for getting him better? All of you. We're all responsible for making him better, for helping him succeed. We're responsible for success, not just holding him accountable. We're responsible for success. So you get a level of leaders that are expected to thrive. But we can't tolerate bad behavior in leaders or in physicians. What you tolerate, you support. If you allow it to happen, you're supporting it. This is really hard. Sitting in a meeting, how many times have you been in a meeting? Somebody goes off on somebody else. You're sitting there saying, nah, she shouldn't be saying that, blah, blah, blah. Yeah, well, you just sit there. You just sit there. If you allow a physician behave badly with a patient, you're supporting that. We just said that can't be. Maureen Bizignano, the CEO of IHI at the time, the Institute for Healthcare Improvement, largest healthcare improvement organization in the world. Here's what she had to say about this. You can't expect your staff to treat your patients in a certain way if they haven't been cared for, respected, and connected. And she's right. So why am I showing you? I'm showing you this to build, this is how we built a disciplined culture around behavior across the organization. So when you have an advanced care planning program, it was consistent with respecting. It was consistent with looking outside. It's consistent with being disciplined. So when it wasn't a huge shocker when a physician, emergency department, cardiac, somebody bypasses a patient's advanced care plan and makes up some crap and does it on his own, that he gets pulled before peer review. Same peer review as any other problem. He goes before peer review to say, come on, man. Patient's wishes are paramount. Why did you make up this other stuff? And it was a very effective part of our organization. We'd always try and support. We'd always try and defy a way forward, but it has to be there. And this is really a big deal. And you know that. This is a picture that shows you something you already know. You already know this. This is the influence of a person in the organization. If she's a star, she can help the CEO get better, help peers get better, improve the work of frontline and other people. She works on teams and develops things, understands where it's at. She can make a massive difference in the organization. But if she's a troll, the dark shadow she casts goes to all the same places, right? Goes to all the same places. So it is not a matter of, it's not a matter of just allowing it and thinking the two people that are officially in her lines and boxes are going to be affected. It's a broad effect. It's a broad effect across organizations that are important. So you got to manage anybody. This is executives, of course, but to a frontline worker, the manager, the supervisor, or director are in this same bucket. That if we allow them to behave badly, the frontline feel less special, more afraid. You think they're going to lean in on your innovation? You think they're going to get excited about the changes you bring? Yeah, I don't think so. I don't think so. You have to show courage and discipline. One of the discipline pieces is for me to behave, which is not a good, easy thing. So I speak to big groups sometimes, and we'll talk about the financial implications of advanced care planning in a fee-for-service world. And I'll say blah, 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 and I'll show our results of over 95% of seniors in the last 2 years of life with their wishes available, outlined, followed, and somebody will stand up and say, well, I'm the chief financial officer of wherever I am, and I know you're a pediatrician, you're probably good at that, but you don't understand the finances here. What you're doing is leaving $10 or $20 million on the table every year. And so I want to say something completely irreverent, and since they're taping, I can't. But it really ticks me off. And I say, well, actually, you're wrong. It's really $30 to $50 million a year. And we don't call it leaving on the table. We call it delivering appropriate care to patients. It's what the patient wants and needs. And you, in fact, are balancing your books on the backs of unwanted and unneeded care for seniors. Yeah, then nobody asks questions for the rest of the time. So I have to always be a little careful of that. But there's so much waste in healthcare. We have plenty of room to do the right thing. We did the right things a zillion times that didn't necessarily make it. It's be disciplined. Again, finance is a tool. It's a tool for us to accomplish other things. It isn't the ultimate goal. Now, during the 14 years as CEO, we put away more savings than we had in the 114 years before that. We had brand new buildings. We had new technology. We had many of these signature national, international programs. We became from a high cost to a low cost provider. 14 years in a row, our fee increase was less than the year before. And we still had the best advanced care planning program in the country. We did fine. We did fine. Why did you do fine? Because you had a bunch of purpose-driven people. You had a bunch of purpose-driven people who that was totally messed up. Okay, coming in different order. Okay, who are willing to lean in on a model that started with patients and families, the conversations and that, and moved farther on, went to the health system, from the community into the health system, taking on responsibility as a responsibility. Again, this is a responsibility. This isn't dominance. This isn't doing what you pay for. It's a higher level of thinking. It's saying we are responsible for the well-being of the community. So we will train providers. We will evaluate and improve along the way. We will make sure that the wishes of the patient are paramount. And we will engage people across the whole breadth of our community. This is a package. It is a package that starts with a fundamental purpose that results in living your values, that is not easy. It isn't mushy. People say, oh yeah, values-based. No, it's really disciplined. Requires a lot of durability, measurement, training. It is not mush, but it is ultimately successful. So, that's enough of me. We have time for questions. I understand it's between us and lunch, but we have plenty of time for questions.
Regarding the financial
Yes.
success at Gundersen, it's independent of the advanced care planning, the fact that your ICU was filled up with people appropriately? Was it independent of that, or was it just based on the fact that you're purpose-driven? So I'm wondering if there's a connection at all between advanced care planning.
Well, the hardest, it's really hard to separate all that out. That's a very good question. I don't know. I thought it was all the charm of the CEO that filled the place up, but others argue with that. I can tell you that I think, what I really think, I think it's because we convinced the community that we were there for the health and well-being of the community and not just another business. Because in the midst of the economic downturn, we built a replacement hospital, the biggest healthcare project in the history of Western Wisconsin, right after the economic downturn. We had more million-dollar donors than ever in the history of our place, times 3, after the economic downturn. Why? Not because they wanted bricks and mortar. It's because they believed they were there for the well-being. Don Berwick, somebody that helped train me, and I listened to him a lot, told me, you shouldn't rebuild that hospital. Don't build that. You aren't going to need that hospital. Well, eventually, you might be right. We went from a census of 180, and now we're pushing 240 all the time, despite having all kinds of outpatient programs and telemedicine and all these things. Why? It's because people want to come there where staff, frontline staff, are inspired to do the right thing all the time. That's their job. Do the right thing. Take care of patients. Make the patient and the family the top priority. So I think it's all tied together. I think it is tied together. And some people say, well, you're too Pollyanna, this, do the right thing and everything will fall in place. That is not exactly how we do it. We do the right thing and we work like crazy to make everything fall in place. Yes, Jeff.
We have several challenges. We are a lead hospital.
Yes.
One of our challenges, we don't own all our physicians, so we have a lot of other groups, independents, trying to get them to come on board and see things in a different way we do. So that's been a challenge for us so far. The second thing is we're in a very competitive market in Atlanta. There are constantly commercials on TV. Other hospitals say, come to our hospital and we'll heal you. If you have cancer, if you have heart problems, we have the facilities that will heal you. And so to start talking to people seriously about advanced care planning, they'll start thinking, well, maybe we need to go to another hospital.
Yeah.
So these are outside cultural issues that we're having to do because we cannot do that.
Right. So the two issues, one is physicians that are not employed. Let me tell you, for people that have worked in both kind of settings, it's still an uphill swim, even if they're employed, because they can go a lot of other places. They're a pretty independent lot. I mean, it's still an issue. It is more of an issue there because they're separated and the communication's an issue and priorities can be an issue. I think that is a hard problem, but I think you have to decide what your organization is there for. I mean, it's not like we didn't have any competition. We had the Mayo Clinic 65 miles away. They came in and bought our #1 referral source that was 7 blocks away from our house. And so United Healthcare, we have our own health plan. United Healthcare came into the area. They're 100 times bigger than us. So we had some competition too, but we just felt that if we stayed with this, we would do okay. As far as coming from the hospital, I think the answer to that is to make it a community effort. Get the media person like Kathy from last night, get the community involved. When we rose this up in La Crosse, it was one of the very smart things that Karen and Bud and a variety of people did in the organization, is that they worked with the faith community, they worked with the synagogue, they worked with the Catholics and the Lutherans and the service clubs and the educational groups, and so it became a community conversation. It wasn't the docs at Gundersen telling you to fill out this form alone, although they ended up doing a lot of that or requesting that. It really was better coming broadly as a community initiative.